So who wants to go first? No volunteers. Anybody want to volunteer?
Yes, sir.
Okay, so today it's going to be all about pediatrics hips. Okay, it's a difficult topic, but once we go through it, hopefully you'll be able to answer questions. The whole idea of the exam is to not be surprised and be able to handle difficult situations. Okay, so, is it Gulfarm, yeah?
Yes, sir.
Tell me about the screening of development dysplasia. What do you know about it?
Sir, when the child is born, we will do a examination like Barlow and Ottolani.
When?
And when the child is born at birth.
So somebody next day, once the child has been born, should do a ward round from the orthopedic team, and they should all be assessed and examined. Okay, good. So what are you looking for on the exam? What is called the Ortolani and the Barlow's test? Yeah. So can you describe both the tests for me?
So Barlow is for a located hip to dislocate a located hip, and it's done by.
Ortolani is out and Barlow is in. So Ortolani is out, it means it's dislocated, and you have to put it in. And Barlow's means if you bring the two legs together and see if with both hands you can dislocate it at the back. So you will do an Ortolani first, and sort of Barlow first, and then Ortolani to put it back in. If it's already out, then you would like to do a Barlow to bring it back in. Is that correct, or is it different?
Yes, sir. It's okay.
You were telling me the other one, yeah? So Ortolani O means out, so it's already out, yeah, and you have to pull it in and abduct the hip to get it in. Barlow is to abduct the hip, bring it together, adduction, and see if we can dislocate it posteriorly. Okay. So what people do you know actually have problems with hip? What children who are born will have problems with hips?
So those who are premature.
Okay, good.
And with the family history, firstborn.
Good.
And female.
Not necessarily, but yes, okay. So far, so good. So if they have twins, if they are firstborn, okay, or a primary gravida with a young lady who's having a first baby, diabetics, or people who have hydramnios, they have big, huge bellies. These people, sorry, not hydramnios, but small. And what does that do actually? So they're tight, isn't it?
Yes. Okay.
Okay, and they're tight, and therefore they cause them to do. There's one more presentation that will give you a dysplastic hip, and what is that? A breech presentation. Yes.
Okay.
Yeah, and they are present with some other abnormalities, especially if there is tight abdomen or the belly is tight and they've got primary gravida or premature babies. That's because it's a packaging disorder, and you may end up with having problems with feet, like different types of unstable feet or dysplastic feet, or people with what we call is the problem with the feet. Yeah. So Talipes equinus, yeah?
Yes.
Okay. So they will have associated, sorry? So they will have associated problems, yeah? So if we can get it right, hang on. Okay, so you were right. There's a female sex, family history, breech presentation, multiple pregnancies, certain condition, neuromuscular condition, oligohydramnios, when there's not enough fluid, i.e. a packaging disorder, and they are associated with clubfoot deformity, and they've got a high birth weight because they're too big for the amniotic sac. Okay, so now that you've got these factors and you have a baby you've examined and it's a clicky hip, what are you going to do next?
It's a clicky. I will reduce with the. I will reduce the hip and advise a Pavlik harness and re-examine after 4 weeks.
Okay, you can't put Pavlik harness straight away because there's a lot of complications with it. So if you have a suspected diagnosis or it's a clicky hip, you will put them in what is called double nappies. You give them double nappies and we'll bring them back 4 to 6 weeks later, do an ultrasound. Okay?
Okay.
They will have double nappies. You shouldn't put public harness straight away.
Okay.
So now you've seen them at 6 weeks, and they have had double nappies. There are two options that can happen. They can either get better, and then on the ultrasound, they have a normal hip, or they still have an abnormal hip at 6 weeks. What do you do at 6 weeks then, if they still have an abnormal hip?
Continue pelvic harness.
So now you put the pelvic harness, okay? You did do them, you did double nappies, but now you put the pelvic harnesses, okay? So when these children are come to you in the clinic, when they're missed, they've not been assessed, which is what Pakistan is all about, isn't it? They don't assess them post-op and everywhere, and they've not had an assessment done, and they come to you in the clinic, what will give you a diagnosis or an indication that this person may have a dysplastic hip?
Sir, up to 3 months, we can do a Autolani and Barlow test.
Not after delivery. You can't do that late. They're only done within the first couple of weeks of their birth. Is it anything after that? You can't do them. So if they come late, what will you do? Say 4 to 6, 8, 12 weeks down the line.
We will see for the other examination findings like asymmetrical gluteal and thigh folds.
Very good.
Limited abduction.
Very good. Very good. Yeah. What else?
Hyperlordosis of the lumbar spine.
Sometimes, not always. What else?
So Galeazzi sign.
Yes, you will have a Galeazzi sign. What else? So you should know this. You know, you have to flow in the exam, not think about these questions. That's why we do these viva practices so you can have answers. So these patients will have these children will have other problems. They may have a TEV, foot problem. They may have, a spine problems or something else. So they may have a packaging disorder with it, or they may be on their own. But when they present, what's the first investigation you will do?
X-ray.
You can do an X-ray. Very good. Okay. So this is summarizing so that we can remember this, because I don't do peds, I don't remember these things, but I've just done this so we don't miss it. So from the birth to 3 months of age, they may be having positive ortolani or Barlow's, but typically in the first 4 to 6 weeks, anything more than that, you can't do the ortolani or Barlow's. They have what we just said, an asymmetric leg crease, such as a gluteal or a popliteal or a thigh fold. They may have apparent shortening, such as Galeazzi's. At 3 to 12 months of age, they will have limited abduction. They will have apparent shortening of the femur, like a Galeazzi sign. They may be laterally rotated, or when they walk, their posture is difficult. And sometimes you can still see the asymmetry of the legs, and we do what is called a Kleisig test. Do you know what a Kleisig test is? Anybody?
No,
So you put your finger on the anterior superior leg spine of the trochanter, and if it is dislocated, there will be more gap on it. It is a measurement that you do. It's not very rigid, but it is one of the tests you can do clinically to assess whether the person may or may not have dysplastic hip. Okay, so we know Barlow's test, we know Ortolani's test. We're very happy with that. Okay, O is out, so Ortolani is always out. You have to put it back in, and Barlow is in. You have to take it out. Okay. So this is the increased folds you will see. This is the Galeazzi's test, and this is the what you call the test we call the Kleisig test. Yeah, you put your finger on the anterior superior leg spine and the trochanter, and that distance becomes bigger in a dislocated hip. Okay, you must compare it with the other side. If the other side is not normal, then you don't need to do this test. Okay. So how do you manage these children now? Now that you've had a child, you need to tell me, or you need to for the exam, how you manage them when you first see them at birth. You see them at 3 months, 6 months, 1 year, 10 years, and 15 years. Do you have a plan? What do you do?
And sir, initial 6 months, we will manage by by public harness, and we will assess after 6 weeks by ultrasound.
Very good. So you keep assessing them at 6 weeks until it keeps staying in. If it is staying with the Pavlik harness, it will work. If it doesn't work with the Pavlik harness, or they present late, what's the next stage you can do for them?
So we will then plan for a semi-rigid orthosis.
So you can do what is called a broomstick plaster. You can take them to theater, and see on the EUA if the ball can go into the socket, or you can reduce the hip. And if you can reduce the hip, you can hold it in that position in a spiker or a broomstick plaster. Okay, so if it does not reduce back into the joint, what you're going to do then
Open, sir.
is what? Sorry.
Adductor not.
No, first thing you will do is do arthrogram with the contrast to make sure there is no pulvinar, which is a big, huge collection into the socket. Sometimes you have to do a medial release, and they may end up going into socket. If they don't go into the socket, then you have a choice of either doing an open release or doing an osteotomy to make sure that it goes and stays in the socket. Correct?
Okay.
Okay. So for up to 6 months of age, you can do double nappies first, then pelvic harness or a hip spiker. Guys, if you're not answering the question, then you need to stay mute so that we can all mute. Okay, good. So you have up to 6 months, you can do pelvic harness. Start with double nappies and then pelvic harness. From 6 months to 12 months, you do a closed reduction and a hip spiker. From 12 to 18 months, you can do a possible close and possible open reduction. After 18 months, you can do an open reduction and acetoplasty. Okay, after 2 years, you have to do an osteotomy. Correct? We happy with this? So the more younger you are, the more non-operative measures you can do. The more older you are, the more open procedures you have to do. Do you know any of the vestibular osteotomies? Does anybody know any of those? There's loads. You can read them up, but you can do the Salters, and then you can do the Pemberton, and you can do a triple osteotomy. These are all various osteotomies to make sure that the head's covered. Okay, and the older they are, the more you'll end up in osteotomy rather than soft tissue releases. Okay, so this is the double nappy. Just make sure we've done double nappies, and this picture is a pelvic harness. This is a young person, so they've done a hip spiker. And this is a broomstick plaster where they put the hip into the socket, and to keep it in the socket, they put a broomstick in abduction so that the hip stays in the socket. Okay? You must. Okay. Right. Can anybody look at this X-ray now and tell me what they see? You've had your go, Gopam. Can somebody else try now? Yeah. There's loads. There's loads. Everybody get a chance, but I want everybody to speak so they can, get the idea of speaking in the exam. So basically, sorry.
So basically, it shows dislocation on the right side. So
Okay.
basically, we have to make. So basically, we have to make few lines.
Very good. Which ones?
So there is H line or Hillinger's line, or we have to make a Shenton line and two indexes. One is the acetabular index, and another is CE index.
Okay, so there's an H line, which is a Hilgren's line, and there's a vertical line. What is that called? Perkins line, yeah?
The Perkins line.
Yeah, so how do you make those lines? Do you know?
So the Hillinger's line, H line, basically it crosses, is a horizontal line, it crosses the triradiate cartilage.
Very good. So
And
how does the
line,
yeah?
and the Perkins line is the vertical line, which basically is on the edge of, is around the edge of the acetabulum.
Okay. So if you look at this is what a H line looks like, yeah? And the Perkins line goes where? To the top of the edge of the acetabulum, okay? And then you have the, what we just said, the Shenton line, okay? So now if you look into this picture here, so what do you see in this picture? So this if you draw a line, it is inside and lower quadrant. This is outside a quadrant. So that means this is a dysplastic hip, yeah?
Yes, sir.
Okay, what about this edge? What is that called? Center edge angle and what does that tell you?
Acetabular index and center edge angle.
Yeah, what does that tell you?
So that will tell you, that will give us an idea about the dislocation. Basically, acetabular index is done before the 5 years of age when the triradiate cartilage is open, and center edge angle is done after 5 years of age.
Very good. So you would know whether the acetabulum is developing or not. So how would you know that, or what is the importance of that? I mean, why do we want to know if the acetabulum is developing or not?
So to know the further contaminant of the head, containment of the head.
So if the head's in the socket, like the cue of the chalk of the the pool or snooker table, it will keep moving into it and make it round and make it normal. If the head's not in the socket, then the acetabulum will not develop, and therefore you will have problems with the acetabulum. That's what it's all about. It just tells you whether the acetabulum is being, the head is inside the socket or not. Okay. So this one is a dysplastic hip. Okay. Why do we not call it dislocated hips? Congenital dislocated is no longer called. It's called development dysplasia now. Why? So nobody uses the word congenital dislocation of the hip. Everybody calls it dysplastic hip. You can say this is dislocated.
So because the head of the femur is not well developed, in case of dislocated hip, the head must be.
So the reason is basically solicitors and lawyers, they say that if it was a congenital dislocation, you have missed it, and therefore it's your fault. However, if you use dysplastic hip, you can say that it developed into such a position that is now dislocated. Like, okay. So that's only to protect yourself, but it's got nothing else to do. It's only to make sure that the wordings are correct. Okay, good. So what are the indication or what are the causes of children with having hip pain? You must know that if less than 4 years, you have an irritable hip, septic arthritis, a juvenile arthritis, non-accidental injury, and referred pain. Okay, and if you're between 4 and 10, you have paeds added onto it, and if you're between 10 and 16, you have SUFI added onto it. Okay. So these are the differential diagnoses of children with hip pain. You need to know what is less than 4, more than 4, but less than 10, and more than 10 years old. So SUFI is above 10, paeds is between 4 and 10, and everything else can be present on any age. Okay, do you know how to, is there an index you know about infected hips? Do you know a formula, a rule, or something to help you tell you that this person has got an infected hip and not an irritable hip?
So basically, there is a criteria called Coccus criteria.
Very good, excellent. Go on. What does that say?
So that will take. There are 4 parts of that. One is inability to weight bear. Another is the temperature. Third one is raised TLC, and fourth one is leukocytosis.
Is it?
I think these are 4 types.
So criteria for the septic arthritis, yeah? Temperature, WBC count, ESR, unable to weight bear and C-reactive protein. So the presence or absence of 4 or more will confirm that it is a infected hip rather than a irritable hip. Okay? Yes, no?
Yes, sir. Yes, sir.
Okay, so the temperature, blood cell count, ESR, CRP, and inability to weight bear, all these, when you look at them, 4 out of the 5 will tell you that this is an infected hip. So what's an irritable hip? Anybody? What's an irritable hip?
So irritable hip is a hip in which these all 4 criteria are not present.
So when a young child comes to the clinic or to
pathologically the synovitis.
Yeah, it's called transient synovitis. But why do you get irritable hip? Why does one get an irritable hip? Nobody knows why one gets an irritable hip. So if you have a systemic disorder or a recent medical condition for the child, such as a flu or a runny nose or something else going on, because of that, the hip has got an effusion in it, and that makes it painful. Okay, and these are transient symptoms that gets better with management of just pain relief. Okay, so the transient synovitis is child will be coming limping, as it would do in most conditions of the hip problems. They will have pain in the thigh or the knee. They may have sometimes fever. That's because something else is going on then. Again, they will be refusing to walk, and children will be crying at the night, and they are unusually crawling longer than normal. And if you examine them, you will have all the features of a painful infected hip. However, if you apply the Coccus criteria, they don't fit into it. Their blood vessel cells are normal, and the temperature is mild. Okay, so how do you what treatment do you do with these guys after you've diagnosed them? Hello?
So
just
rest.
So you will ask for an ultrasound to be done and see if an aspirate can be done, and that can be sent for cytology, yeah, or for cells. You can then rest them and pain relieve them. So if you send the child home, what are you going to tell the mom?
We are going to tell them if the symptoms get severe, if it becomes afebrile, or the pain is not resolving.
But that's not what peds guys do, isn't it? That's what you and I would do. But what would the peds guy tell them? What they tell mom is to get a book, and she has to write every time the child was unwell or painful or did not want to walk on it. She makes some diary for it, and when you see her in a couple of weeks' time, she brings that diary to you, so you know if the child is getting better or worse, much the same. And as you said, you tell the child, the parents, that if the child doesn't do well, you need to bring him straight away. Like, okay, everything else is normal, but with the rest they get better. Most of them get better with rest.
We will do aspiration and all the.
You have to do an ultrasound. You have to do an ultrasound. If there is a collection, then you have to aspirate and take it for microbiology and for cells. If there is there's no effusion, then you leave it alone, because the differential diagnosis is with infection, and you cannot miss infection.
Oh.
And these are the common organisms at different age, but I'm sure you've learned that for your MCQs, yeah?
Yes.
Okay, so who wants to go next?
Okay, now?
Yeah, of course.
So basically, it's an X-ray pelvis of a slightly immature patient showing slip capital physis on the left side.
Okay. So how do you know? I mean,
so I will make a radiological line, one line which is known as Killen's line.
okay.
Basically, that Killen, sir, basically.
God, I can't hear you now.
Hello.
Yeah, go on.
So basically, that Killen's line must pass the proximal physis. In this case, it's probably the physis are a bit.
So if you draw a line from the neck into the head, it will cut it here, yeah? And this one is not cutting into here, yeah? So clean lines is an American way. If you were living in England, we don't call it a clean line, we call it something else.
Okay.
What is it called? It's called the Tritant line, okay?
Okay.
The Americans call it Clean's line, but the English call it the Tritant line because our guys discovered it first, so that's what we think anyway. Like, so you need to know who your examiner is, and maybe if it's an English trained examiner, you need to know that it's also called a Tritant line, okay? So what is the management for these patients then?
So after a history and detailed examination, the management will be in situ fixation.
Okay, and clinically, what is this stable and so you need to describe them into three different type of classification.
So there's a loader classification. There are two types. One is stable, another is unstable. If the patient is able to weight bear, that is stable one. If he's unable to weight bear, that is unstable.
So okay, exam का आंसर ये है कि classification की तीन types होती हैं. One is depending on the onset, whether it's acute on chronic or chronic. Two is the weight bearing status of the child. If the patient can weight bear or unable to weight bear, therefore it's stable or unstable. And the third classification, depending on the slip, how far the slip is from mild, moderate to severe. Okay, so you can have a loader classification too, but with a mild slip and it's a chronic slip. Do you understand what I'm saying? So classification of these is basically dependent on three different types. Okay, उसकी reason ये है कि अगर acute slip है तो आप उसको थोड़ा सा manipulate कर सकते हैं, लेकिन अगर वो chronic slip है फिर आप उसको manipulate नहीं कर सकते क्योंकि उसकी blood supply खराब होती है. But the management plan for these is fixation in situ. Okay, how do you fix these?
So by a single cannulated screw.
Well, that's an easy way of answering it. But reality में कैसे इसको fix करोगे? कभी क्या है इसे fix?
I've seen my consultant, but I have individually.
कैसे करते हैं? कैसे किया उसने?
So in situ fixing के left lateral position में sir anteriorly डालते हैं in middle in the center of the femoral head.
ये इसका मतलब नहीं देखा है. पहले जो है ना उसकी एपी पिक्चर लेते हैं और उसके बाद उसकी लाइन ड्रॉ करते हैं फ्रॉम द मिडिल के वो हेड के बीच में से जा रहा है कि नहीं जा रहा है. उसको पॉइंट जो है ना वहां से ड्रॉ करके एक पॉइंट पे आ जाता है. फिर उसके लैटरल पिक्चर में देखते हैं, पेशेंट को नहीं मूव करते हैं, एक्सरे को मूव करते हैं लैटरल. उसके बाद वहां पे सेंटर से जो है ना लाइन ड्रॉ करते हैं, तो जहां वो पॉइंट मीट करता है, when it crosses, you have to go in the direction of the two lines, in the center AP and lateral, and that's what you do. It is called a fixation in situ. ठीक है?
Okay, sir.
You must remember this for the exam. Okay, otherwise पता ही नहीं कि किसी ने देखा है कि नहीं देखा है. Okay, so mild, moderate, and severe है. Okay, और risk factors की basically obesity होती है या endocrine होता है. What is the incidence of having it on both sides?
20%.
How much?
20%.
20%.
Very good. It's 15 to 20%.
27. 27
What,
to
sorry?
28%.
15 to 20%. Okay. So
27 to 30%.
इतना नहीं है यार, 15 to 20% है. But how do you fix the other side? किस वाले को fix करते हो?
In high risk patients.
Is what, sorry?
In high risk patients that who are obese or with a
Endocrine problem.
endocrine problems.
Yeah. वो एक होता था वो जो क्लासिफिकेशन थी सॉल्टर्स की, याद है? वो सॉल्टर्स प्रोफेसर था ऑर्थोपेडिक्स का उसमें लंदन में, तो उसने कहा था द व्हाट साइन. अगर पेशेंट के पेरेंट्स को कहोगे इसको जो है ना स्लिप्ड सूफी है और अगर उसको दूसरी साइड का प्रॉब्लम हुआ तो हम उसको फिक्स करेंगे. अगर पेशेंट कहता है व्हाट, तो आप दोनों साइड फिक्स कर देंगे क्योंकि यू डोंट वांट टू रिस्क द चाइल्ड विल लूज हिज हेड. So 4 reasons. 1, if they have obesity. 2, if they have endocrine problems. 3, if they're very tall. And 4, if they say the what sign, which means their parents don't know what to do with that child. Okay? अच्छा, ये एक और क्वेश्चन एमसीक्यू में आता है, लेकिन हो सकता है आप लोगों को पता हो. Where does this slip occur on the hip? जो हेड होता है उसमें कहाँ होता है ये स्लिप? ग्रोथ किस जोन में होता है?
Hypertrophic zone.
Hypertrophic.
Very good. Okay. So ये आपकी क्लाइन या ट्रूथांट लाइन जो आप कह रहे थे ना, इसको ट्रोकेंटर से नेक से जाता है तो उसमें जो थोड़ा बहुत हेड आना चाहिए. Okay. Good. So ये क्लासिफिकेशन we've already discussed. Stable, unstable, mild, moderate, severe, acute, chronic, and acute and chronic. Yeah.
Yes, sir.
Loaders classification. अच्छा, ये आपने पिन डाली हुई है, स्क्रू दोनों साइड को bilaterally fix कर दिया, ठीक है? How do you know that the screw is not intra-articular?
Sir, there's a way of basically these screws are the cannulator screws. So
Right.
what we do, we put a die inside the cannulator screw. If the die is inside the joint, then we'll say probably the screw has penetrated the joint.
Very good, very good. That's very good, yeah. Because if, like you said, it's a cannulated screw, you put a wire and put a screw on top of it, and if the screw actually has got a contrast into the hip, then becomes an arthrogram. That means you have penetrated the joint. That's because slip जो होता है normally posterior तरफ होता है. AP में तो ठीक नजर आता है, लेकिन lateral side में पीछे से निकल सकता है ये. ठीक है, good. I think we've done it. Okay. For today, that's enough. And more pediatrics for me than anybody else can imagine. ऐसे कोई question है इस पे जिसको पूछना हो जिसका जवाब सही नहीं हो?
What about the osteotomies?
Yeah, you
And
tell
what
me.
are
I'm not a pediatric surgeon. I know some, but I can. If you tell me, I'll see whether you're right or not. So you can do an osteotomy at various levels and at various age. Early age में intra-articular osteotomies की जाती हैं और late age पे femoral osteotomy की जाती हैं. ठीक है? Which ones do you know?
So done osteotomy.
The done osteotomy is done at the physis. Okay.
It's a subcapital lesion.
उसमें से यहाँ से वेज निकालते हैं, यहाँ से वेज निकाल के इसको चेंज करें. और
Southwick osteotomy.
साथ
Left, sir.
वो नेक पे की जाती है. और
Ellipse, sir.
sorry,
Ellipse.
I don't know that one. Yeah. So you can do the osteotomy depending on the type of slip you have. If it's a too much of a slip and it's a young child, then you can only do this osteotomy which is distal into the joint, and you have to be a very good pediatric surgeon. Not everybody is allowed to do these osteotomies. It should be done by people who know what they're doing, because if you make a mess of it, you ruin the child's hip. When they become older, then what you do is do an arthrogram, and you see which is the best position for the hip to be in. In that position, then you do a femoral and a neck osteotomy, so you can hold it within to make sure that the head is in the joint. And then you hold those with a broomstick plaster. But again, these should be done by people who know what they're doing. So exam का safe answer ये है, osteotomy किसी ने पूछा था, उसका जवाब ये है कि I'm aware of the osteotomies. The more severe the problem is, and the more younger the child is, it is done around the neck and the physis. The older the child is, it is done in the femur. But these should be done by pediatric consultants who do this for a living rather than somebody who doesn't know what he's doing. Agreed?
Yes, sir.
Exam में ना वो start में आपसे हर एक पूछने लगे ना तो फिर तो बहुत ज़्यादती है, लेकिन they just want to know if you're safe or not. That's my experience anyway. Next, और कुछ?
That's it.
No, everybody's happy.
Yes, sir.
Remember
Yes, sir.
that.
Thank you.
You need to understand कि जो है ना स्क्रीनिंग सिस्टम क्या है डिस्प्लासिया का. बच्चे जिस दिन पैदा होते हैं ना सबको जो है EUA करना है, Ortolani and Barlow's test, ठीक है? और अगर बच्चा जो है ना क्लिकी हिप है तो उसको डबल नैपिस करके 6 हफ्ते में अल्ट्रासाउंड करना है। लेकिन जो बच्चा क्लिकी नहीं है, वो ऑटोलानी है, बाहर चला गया, अंदर नहीं आ रहा ना, उस पेशेंट में फिर रिड्यूस करके उसको पब्लिक हार्नेस डालना है। इफ दे कम आफ्टर 12 वीक्स और उसके बाद भी अनस्टेबल है, तो देन यू शुड डू व्हाट इज कॉल्ड अ ब्रूमस्टिक, पुट इट इन and you can correct it by holding it in the broomstick. If they come later, then you have to do osteotomies to put it together, either an vestibular or femoral, depending where the problem is. In irritable hip, you must also always exclude infection. You must know that what is the difference between irritable hip and infection. Okay? In Sufi, we must know कि कितना slip है, क्या slip है, किस तरह fix करना है, कौन सा unstable है, किस तरह क्या करना है. If you know this, you have 3 topics of the hip covered in the children. Hopefully, we'll soon do paeds and club feet and all that kind of stuff. But मेरे लिए बहुत मुश्किल होता है. I don't do feet. For me, these are difficult. I can only do it as much as I understand. So slowly and gradually. Okay. Happy?
Happy, sir. Happy. Thank you.
Should we stop it? We'll come back maybe tomorrow, yeah, to do something more.
Okay. Thank you.
Thank you.
Okay, sir. Thank you so much, sir.